Friends and colleagues, good afternoon. And how is everybody today? That's your chance to go ahead and say, it's great, Ed, actually. We're having a wonderful day so far, and we're going to enjoy this. How's that? Can you say all that in one quick sentence? No. Okay. How about just this? How about just, hello, Ed? Hello. Thank you. You care. I feel so much better now. My name is Ed Berliner. Thanks for joining us on this Medscape Live presentation of new monitoring trends to support diabetes practice, an update for managed care professionals. It is time to bring you into our little game show here today, because that's what we're going to be doing. It's a little competition. Everybody likes a little competition here and there. So you're going to get a chance to basically watch all the questions as they go by for the AMCP Nexus Quiz Show. This is the big time, the big guns. And if you look on your table, you'll find out exactly what team that you are a part of. You are either a ketone keeper, a glucose guru. Everybody wants to be a guru at one time in their life, right? Or if you're watching us virtually, you are part of the monitoring mavericks. Oh, you crazy mavericks, you. Let's remind everybody then of how we're going to do things here today, because you get to use your smartphone, your own tech, to be part of the interactive experience here. Scan the QR code with your mobile device. You each have one of these in front of you right now, one of the little placards. You have a QR code right there. Go ahead and scan that. Open the browser, connect to the network. There you see the network password, so you can go ahead and join us, because as the day goes by, you're going to be involved, because you get to view the slides this way. You get to access all of today's content. You will be asking questions because there will be a Q&A at the end with our faculty, and there will be polling involved. See, that's the competition part. We ask questions, you tell us, and we show the brilliance of this audience. Right? Right? Okay, good. Wanted to make sure, get into it. Our faculty here, which we are going to introduce in depth in a few moments, but just to recognize them, from the far end, Dr. Susan Cornell, next to her, Dr. Curtis Triplett, and next to him, Dr. Diana Isaacs. I'll be introducing them momentarily to everybody. So we have already set the teams. Coming up today, you will see round one, updates in quality and safety metrics, the diabetes edition. Round two, data and decisions, continuous glucose monitoring in patients with type 2 diabetes. And then round three, automated insulin delivery and continuous ketone monitoring in diabetes management. What is on the horizon? And then we will have a Q&A at the end, so make sure you keep that all in mind. Let's go ahead and get started with round one here. Updates in quality and safety metrics, the diabetes edition. Allow me to introduce the Professor of Pharmacy Practice, Director of Experiential Education at the College of Pharmacy at Midwestern University in Downers Grove, Illinois, Dr. Susan Cornell.
Well, thank you, Ed. Welcome, everyone. All right, we're just going to jump right into this, and let's get the game show started. So go ahead, get your smartphone out, because we have three questions in round one. So we are going to start out with talking about defining CGM metrics, which is, what is the recommended glucose time and range for non-pregnant adults with diabetes? Is it between 70 and 120 milligrams per deciliter for more than 50% of the time, between 63 and 140 for more than 70% of the time, between 70 and 180 for more than 50% of the time, or between 70 and 180 for more than 70% of the time? And I'll turn it over to Ra, who's going to calculate all of your answers as they're coming in. All right, and let's get the music going.
You're doing this for your team, remember now.
That's right.
It's a competition, everybody gets involved.
Great prizes.
Careful of those mavericks on the virtual line. They know that they're hiding out there. They could be the unknown factor.
Okay, so it looks like we're kind of tied between a few different ones here. Very close between number 4, but number 2 is falling slightly behind there. All right, so let's talk about what are the metrics, time and range. It is between 70 and 180 right now at this current time. So we're looking for most people with diabetes to be between 70 and 180 milligrams per deciliter. And this is within a 24-hour period. So we're looking for 70% of a 24-hour period, so within one day, for them to be between 70 and 180. And that's currently the definition of time in range. Now, that changes subtly for pregnancy. So individuals who are pregnant, we get a little tighter control between 63 and 140. So again, 70% time of within 70% of the day. Where it differs is in older adults, and being an older adult in the room here right now, I'm kind of a little offended by that statement. But I think it's individual, and we need to recognize that. I have a 90-year-old sister-in-law who can run circles around all of us in this room. So age is only a number, but then, I've worked with people that are in their 50s who are high risk. So we have to be careful on how we're setting time and range. So again, in general, those of you who picked 70 to 180 for greater than 70% of the time, that is correct, but no, that's not the end-all be-all. Now, time in range is one puzzle piece of this entire ambulatory glucose profile. When we're working with people with diabetes, it does not have to do with one number. It has to do with multiple puzzle pieces. And this is where CGM, continuous glucose monitoring, the sensors, provide a ton of puzzle pieces for people to better manage their diabetes, their overall health and lifestyle. So when we look at an ambulatory glucose report here, the very first thing is what percentage of the time is that CGM active and how long have they been wearing it? So we need to have at least 10 days worth of data for the numbers to be accurate. And we also need to make sure that that CGM sensor is active at least 70% or more of the time. So looking here, 14 days, 92% active, wonderful. I had a patient not that long ago who had 55% accuracy or 55% CGM active in 7 days because she had just changed her sensor, she was off of it for a week, so there was a delay in her getting a lot of the data. So all of the numbers were not able to really be used because again, she wasn't wearing it long enough for us to get accurate data. And it was too bad because she had good time and range, and hopefully it continues. But bottom line, first thing you look at is that glucose sensor activity, then how low are they going and what is the frequency of that low, and then time and range, and then also how high they can go. Now, some other important factors are what we call the CV, the coefficient of variation, which is the glucose variability. I'm going to come back to this in a bit because we don't want that to be too wild. We want to keep that variability within a little tighter range of area of range. Okay, so now we know that A1C, we've always known for the past few decades, A1C correlates to blood glucose. So for those people still doing finger sticks, if they're doing finger sticks and for the most part they're getting 150, we anticipate that their A1C will be around 7. But what we now know is when we put all these puzzle pieces together and we look at time in range, we know that when we increase time in range, the A1C comes down. If we decrease time in range, the A1C goes up. So it's inverted. So the more time in range, the lower the A1C. And that's where, again, we're looking at maybe an A1C, if you have an A1C roughly here, maybe 7-ish, we expect the time in range to be around 70. And A1C that is 8, we expect the time in range to be about 50. So you can see, again, it's better when we have a higher time in range. All right, get your phones out for question number 2 as we look at benefits of CGM use in people with type 2 diabetes. All right, which effect does the use of CGM have on people in type 2? So is it decrease all-cause hospitalizations, decrease treatment satisfaction, increase in A1C levels, or reduces time in range? And let's go ahead and get those votes in. Folks at home, don't forget to vote. Okay, all right, this was an easy one. Thank God everybody got it. Yes, absolutely correct. So obviously this is going to, by wearing CGMs, we're decreasing all-cause hospitalizations. So there's so many benefits that come out of it, and this is looking at people with type 2. So not only are we preventing them going to the hospital, we're improving their health. By increasing time in range, we're decreasing how many times they go low. We're decreasing how many times they go high. They feel better. I've been doing CGM for years with adults with diabetes, mostly type 2 in my practice, a few type 1s. But overall, I can tell you they come back. I get boxes of candy. I'm not sure what it is about giving candy to a diabetes educator, but okay. They're so happy because they feel good. And when we're improving their time in range, their A1C goes down, and then they feel like they've done well. Now, with that being said, we do need to make sure they understand how to read the reports and how to interpret some of these numbers, because without that, then it could be a little bit of a problem. And I will tell you, I've had a number of people who they don't understand where they're supposed to be. What is that time in range? Do I get to the gray box? How do I get there? And this is where CGM actually helps them make life decisions to improve, again, their overall well-being and their health. Now, the other thing too, when we talk about CGM, what does it do for the person wearing the sensor? They get to make decisions. So right now, if all of you were wearing a sensor, you would be knowing what the food is doing to your sugar. You'd be getting an idea of, oh, well, if I ate my bread first, did it spike my glucose up? What if I ate the salad first, my fiber, my greens and vegetables? My glucose didn't go up as much. I just walked around the whole National Harbor and my glucose kind of maintained or actually went down. I will tell you, my students at the university in our diabetes elective, we do a CGM wear experience. For 2 weeks, the students have to wear a CGM. And we tell them, challenge the CGM. Eat what you would normally eat. And I will tell you, I know one student, he went out into the Chinese buffet and he said, I never believed how high my sugar could go. Students were having drinks that had maybe more sugar in them versus those with less sugar. And most importantly, what does your sugar do going into an exam versus coming out of that exam? Stress, lack of sleep. We don't realize how that plays an impact on our sugar. And this is the same report that I get from my patients. I have a patient right now that we're working with. Her daughter moved to Washington State with her granddaughter because obviously work. Now she misses her daughter and her granddaughter. She's very upset, she's worried, and her sugars are going up because of the fact she's stressed. What can she do to better manage her diabetes with stress reduction to bring those numbers down? So again, these are life decisions, health decisions people can make just from the data that they get from a CGM. Okay, let's go to our final question, which is performance measures in the metrics. Which minimum coefficient of variation on an AGP report represents an increase in glycemic variability? Is it greater than 12%, greater than 24%, greater than 36%, greater than 48%? And I'll know if people were paying attention because this was on a previous slide.
By the way, Dr. Cornell, I don't think you have to worry about being called a senior. We consider ourselves veterans.
Veterans, oh, I like that.
See that? Yeah. Go with that, experienced veterans.
Experience.
Instead. There you
yes.
go. I'm going to teach these young kids. They're going to come to us for experience. There you go.
That's right. I like that better. All right, folks at home, don't forget to get your answers in. Okay, so it looks like some people were paying attention to the slides. Others maybe took a nap there. I can see seniors falling asleep, nap time. All right. Anyway, let's move on. So in general, I want to preface this by saying, for the most part, if you see greater than 36%, that tells you, yes, something is going on. There's a lot of fluctuation in the glucose. So meaning the glucose is up and down and up and down, and that does damage to the cardiovascular system. That damages the endothelial system, that affects your brain. I mean, think about, do we ever feel sleepy after eating? Glucose fluctuation. So by keeping the fluctuation in a tighter range, we don't have some of those effects. Now, I say this very cautiously because of the fact I had a patient in clinic not that long ago. Her CV was 14. Wonderful, right? Except her starting glucose was 220. And so she was in a tight range, but that tight range was 220 to 320. So even though her variability was not there, she was starting at the above marker, meaning her time in range was 10%, her time above range was 90%. So again, remember, all of these little puzzle pieces are just that, a puzzle piece that has to be put together. But for the most part, if their time in range is reasonable, and their CV, the fluctuation, the variability is greater than 36, that's where we're looking, okay, an intervention is needed. Now, the other metric that was mentioned on the AGP is the glucose, I'm sorry, I just drew a blank there, glucose management index. I want to say monitoring index, too many acronyms in my head, glucose management index. Now, this is, again, a number by itself, and it is projecting, the GMI is projecting what an A1C might be. But keep in mind, you're measuring two different things. You're measuring interstitial fluid versus blood. And if you have a person who has anemia, pregnancy, I point to Diana because she deals with a lot of people with pregnancy.
Not because I'm pregnant.
Not because she, right. 7 children later, she's not pregnant.
So we had breaking news working here for a second.
Yes, I've worked with her numerous times when she was about to deliver. So, yeah, not today. But bottom line is, when we have change in turnover in red blood cell, that A1C value might not be accurate. And so if we're using the A1C as a metric, okay, good, but it's only giving us limited data. And again, one part of the puzzle piece. So we have to look at not only the GMI, but the entire ambulatory glucose profile, time in range, as well as A1C, in order to actually better manage our people with type 2 diabetes. And from this, I believe I am going to kick it back to Ed, who is going to share the leaderboard.
It is time to get to the leaderboard then, because this is the breaking news. Have you been paying attention? Of course you have. See, you knew that right away. Here we go on the leaderboard. The ketone keepers. Give yourself a round of applause. Look at you doing very well there. The monitoring mavericks. That's right, you mavericks out there in virtual land. Coming in second right now, and the glucose gurus have a little work to do. You got a little time to catch up. It's okay, we got time. So let's go ahead and get on to round 2 now, which is data and decisions, continuous glucose monitoring in patients with type 2 diabetes. Allow me to introduce a clinical professor of medicine diabetes at the University of Texas Health, the Texas Diabetes Institute in San Antonio, Texas, and someone who can actually tell us that there is no more breaking news. So I'm just going to go ahead and listen. Dr. Curtis Triplett. Dr. Triplett.
All right. Well, thank you so much for the introduction, Ed. We're going to go ahead and get started with some data and decisions, and we'll talk about CGM, and now we're going to concentrate more on type 2 diabetes. So we'll talk a little bit about standards of care, clinical practice, and then we'll kind of go into what a lot of people are thinking about these days, which is non-insulin therapy. Do we use CGM in non-insulin therapy? And if we do, how is that going to help us in our therapy? So let's first start off with standards of care. All right, so this is, go ahead and pick up your phone. Round 2, question 1. According to the 2025 American Diabetes Association Standards of Care, in which of the following patients with type 2 diabetes should use of CGM be considered? Those taking insulin, those taking any injectable, that would be such as insulin or a GLP-1 receptor agonist, taking any anti-hyperglycemic agent, injectable or oral, or for all of the above. All right, go ahead and start answering now. Hopefully you guys can get ahead and be the top of the leaderboard.
Life's a competition. There you go, it works.
We're naturally competitive.
Exactly, we are.
All right, very good. So it looks like a lot of people were on the right track here, thinking about that CGM therapy could be appropriate for just about any patient that you have with type 2 diabetes. So the real question is, could be. So we need to talk a little bit more about this particular instance, about how we could. Of course, we know from a standpoint of insulin therapy that anyone in insulin is potentially someone who could benefit from CGM therapy. And that's actually what the American Diabetes Association currently recommends, is that you can use real-time CGM or intermittent scan CGM in any of these patients in type 1 or type 2 on any type of insulin therapy. So that means they could just be on basal insulin therapy and still qualify for CGM therapy. But the real question is, what about CGM and non-insulin therapies? So currently the American Diabetes Association says, consider using real-time CGM or intermittently scanned CGM in those treated with glucose-lowering medications other than insulin. And now here's where it becomes interesting, is where you have to maintain individualized glycemic goals. So the real question is, what do we need from that person in order to clinically think about this person to get them to where CGM would be an option? And really what we're talking about here is their circumstances, their preferences, their needs. And now CGM becomes more and more available for our patients. And so because of that, one of the nice things about it is that we're able to get some of these glucose readings for our patients very easily. And so clinically, that's a big advantage. It's a feedback mechanism to them, which I'm going to talk about here at the end of this talk today. But the feedback mechanism is really helping our patients to understand what happens with their own interventions. Now, if we want to get technical, Medicare currently has guidance for CGM use, and I think most of us are familiar with this. If you're not, let's go through some of those criteria about where Medicare currently allows CGM to be covered. So number one, of course, you have to have diabetes, be insulin treated, or have problems with hypoglycemia. You need prescriptions, and you need to be able to show that you can do some of those testing supplies and testing of your blood glucose and things like that, and be trained. And this is education. Because one of the things that's most important with CGM, as you guys probably know, is if we just give them a tool, but don't tell them what the tool is for or how to use that tool, the outcomes are not going to improve that much. That's where education is so important for us to give to the patient in order to make them understand the connection between point A and point B. That means whether it be the diet, whether it means the exercise, whether it means something going on, as Dr. Cornell was talking about, stress or things like that, in order to understand how that went to be, which is their glucose. And then, of course, we need to make sure that they've seen their provider in the last 6 months. The other side of the coin is if you're having problematic hypoglycemia, and that would be someone who's having a glucose below 54 on persistent attempts, despite you trying to adjust their medication, or a history of someone who's had altered mental status or physical state requiring third-party assistance, that would also qualify you for CGM use. So in clinical practice, let's talk about where we might use this and how we might use it. So here's round two, question two. Go ahead and pick up your phones. What is the recommended minimum time per month of CGM use? Is it 28 days, 80% of each day, 10 days, at least 18 hours a day, 14 days, 70% of data from 14 days, or it depends on the CGM type? Go ahead and answer now. All right, so this one was a little more varied. We have two front runners. One was 28 days, 80% of the time. But you did get most of it from 44% was the number one answer. And that's 14 days preferred, 70% of the data. And if we look at that a little bit closer, one of the things is that we do have to have a minimum amount of data from the CGM in order to understand what's going on with the patient. This is a general standard. It's not something that has to absolutely be met, but it's something that can help with specific health goals and how to use the data. And we can actually use this in combination with other things. So, for example, I have a lot of patients who may not afford, I work in a lower socioeconomic clinic, they may not afford doing the CGM all the time. But what they do a lot of times is they're going to check their blood glucose intermittently with blood glucose. But then what's going to happen is the 14 days before they come in and see us, they're going to use a CGM. And they're going to use that CGM in order to get really good data for us, in order to come in and visit with us. And we can use that in order to adjust their therapy. So there's very different ways that you can use this in order in clinical practice to kind of optimize the outcomes for your patient. Last but not least, we have GLP-1 receptor agonist therapy. Now, this tends to be more of something that people are thinking about. It makes sense because we know GLP-1s not only help with fasting glucose, but also with postprandials. So we can get a lot of good information from CGM for patients on this, but we need to understand the lay of the land a little bit better for CGM and what I would call non-insulin therapy. So from a US payer perspective, what is true about CGM cost effectiveness when added to a GLP-1 receptor agonist therapy? One, there's no difference in cost effectiveness versus GLP-1 receptor agonist therapy alone. Is it two, it is less cost effective versus GLP-1 receptor agonist therapy alone? Or three, is it more cost effective versus GLP-1 receptor agonist therapy alone? Go ahead and pick up your phones and answer now.
You can see some of the teams are a little more into it right now. They're a little more engrossed in it right now, making sure that they make up.
Some of the tables out there look a little perplexed. Some of them look like they might be smarter tables. I'm not sure.
But when they do this, that's what it all
Yeah.
is. It's the thoughtful process that works.
All right, so very good. So from a U.S. payer perspective, what is true about CGM cost effectiveness when added to GLP-1 receptor agonist therapy? And it is more cost effective. At least most of the data shows us that it is more cost effective versus GLP-1 receptor agonist therapy alone. Let's take a look at a little bit of some of that. So this is some CGM economic evaluation data. And what we have here is they did a study where they look at 10,000 interactions over a horizon of about 40 years with 3% discounting. And what they did is they wanted to look at GLP-1 plus CGM versus GLP-1 therapy alone. And what they found is that when you looked at the incremental cost, that it was about $40,000, $41,000, which is reasonable for cost intervention for CGM. And if you looked at the subgroup not using intensive therapy, it was exactly the same, about the same cost. So what we're talking about here is it's not just insulin therapy with GLP-1 receptor agonists, but when we get into some of these non-insulin therapy types of interventions, they can help our patients to cost effectively lower their A1C. Well, what is some of that data? Oh, I guess that slide dropped. Oh, there it is. I must have gone over it. I apologize. So there's some data out there showing a two-phase crossover study. So what they did is they took patients, small number of patients, 47 in this particular one on your left-hand side of your slide. And what they did is they just did a baseline blinded CGM, but then they did 90 days follow-up after that. And what they found is that people really did do better when they were able to incorporate the CGM into their clinical practice. They found that in general, average glucose came down about 40 milligrams per deciliter. Time in range increased about 25%. They were able to decrease their hemoglobin A1C about 1.5%. And they also found, very importantly, again, remember, these are people not on insulin therapy. They had greater initiation of SGLT2 inhibitors and GLP-1 receptor agonists. Putting all this together and doing like an ACC type of cardiovascular risk, what they found is there was a significant reduction in 10-year predicted cardiovascular risk for those patients. So some not clear outcome data, but some data that shows us that everything is looking quite good. And on the right-hand side, what we see is in a larger number of patients, this is just below 1,500 patients, there were significant reductions in people who had retrospective observational studies, de-identified claims data, looking at type 2s with GLP-1 therapy. A lot of them were on insulin therapy, but the most important part was it didn't matter if you were on intensive insulin therapy, non-intensive insulin therapy, or you were on no insulin therapy. You got about the same A1C reduction by adding the CGM. So very important for our patients to understand that this can help patients get to goals. So the real question is what's going on here? I think we all know, but I just want to make sure that we drive home this point very clearly. One is that 99% of diabetes management is done by your patient, not by y'all, not by the healthcare provider. We only are seeing the healthcare provider for a very small amount of time every year. So that education is so important in that small amount of time. And the remaining time each year, they decide what to eat, they decide how to monitor, they decide about physical activity, and they decide about their life. And one of the things that's most important to understand is they need tools for feedback. And my last slide for you is that this biofeedback loop that happens in diabetes is very important with CGM. So it's important that our patients get the proper education in order to have this biofeedback where they're taking this particular biomarker, that biomarker is CGM glucose readings, and they're actually converting that into understanding more about their life. So that has to do with their diet, their exercise, their interventions, and using that overall. If we just give them the tool, but we don't give them the education, or they don't incorporate it into their lives to make changes, then the tool will not help them get better outcomes. But the outcomes are better if they use the tool appropriately. Thanks.
Dr. Triblett, thank you very much. All right, time to move on and see who has been paying attention. You've all been paying attention, right? Here comes the leaderboard now, the ketone keepers. Very nice, nicely done. Statement up in there, 4,000 over, it's very good. The monitoring mavericks, the virtual folks, still in second place, and the glucose gurus. Come on, gurus, we know you can do it. We know you can add something in there, gurus, get to it. Got a lot of time here, it's all right, don't be confident, it's all right, it'll work. Let's get to round 3 now. The automated insulin delivery and continuous ketone monitoring in diabetes management. What is on the horizon? Allow me to introduce the endocrine clinical pharmacy specialist and director of education and training in diabetes technology, the co-director of endocrine disorders in pregnancy, at the Cleveland Clinic, Endocrinology and Metabolism Institute, and also someone who can attest to the fact that the hand warmers you got coming in work, and they are good, so use them well. Please welcome Dr. Diana Isaacs.
Awesome. Well, thank you. It's great to be here, and I feel I have the most exciting section to talk about. And it is true, despite being from Cleveland, I am cold, and these hand warmers are fantastic if you haven't tried them yet. All right, so what are we going to be talking about in this section? So we are going to talk about CGM integration with automated insulin delivery systems, or AID. Then we're going to talk about the burden of diabetic ketoacidosis, or DKA. And then lastly, continuous ketone monitoring, which is on the horizon. So let's get started with CGM integration with AID. And that brings me to our first question of this section is, which of the following CGMs can pair with at least one insulin pump for automated insulin delivery? And so our choices are the Dexcom G7, the Libre 3 Plus, the Eversense 365, the Simplera, or all of the above. I'm rooting for you, glucose gurus. You can do it.
Come on, you gotta come from behind. That's what it's all about, competition. You get down, you come right back up again. Well, the Mavericks, I think, have a little something working on that virtual side.
Well, the Mavericks don't have the hand warmers.
See, there you go. The ketones and the glucose you're able to do the hand warmers while we're here. You're gonna need them outside today.
All right, you guys are awesome. Yes, the correct answer is all of the above. Fortunately, we have multiple CGM options, and we are seeing more interoperability than ever before. So all of them have some capability to be combined with an insulin pump for automated insulin delivery. So how does this work? So with AID systems, we have a CGM, which is monitoring glucose levels at least every 5 minutes. And then we have our insulin pump, which is delivering insulin. And then there is an algorithm that determines this insulin delivery based on the predictive glucose values, and it can either increase or decrease insulin based on what someone's target glucose level is. And they all have different software and the capabilities to work with mobile apps. And with some systems, people can actually give insulin or bolus through their mobile app. With some systems, everything is controlled from the phone. But the great part about these phone apps is now we can access the data through them. In the olden days, we used to have to plug in all the insulin pumps to download the data. Now it's easily accessible via the cloud, and that really facilitates virtual follow-up. So how exactly do these systems work? Each algorithm's a little bit different, and we're not going to get into the nuance of all of that, but they all have similar way in that they work, right? So they're going to be increasing insulin every 5 minutes or decreasing, or those diamonds that you actually see on there are times when it's completely paused. All insulin pumps work with a rapid acting insulin, and that serves as both the background, the basal, and the bolus insulin. But one of the things I do like to stress, and I want to make sure my patients know, is that these are all hybrid closed loops right now. And what I mean by that is the user is still asked to either enter their carbohydrates in or at least announce their meals. So some systems do allow you to just announce if you're eating a usual meal, less or more. But people will have more time in range if they at least announce or bolus. All right, so what do the guidelines say? Like, who should be using these systems? Our guidelines are very, very strong in the ADA standards of care that these should be the preferred insulin delivery method to improve glycemic outcomes and reduce hypoglycemia in both youth and adults with type 1 diabetes. That is a level A recommendation. So if you know anyone, if you have any patient with type 1 diabetes that is not on an AID system, we should be asking why and make sure we have offered. People still have the right to say, I don't want to wear an insulin pump, but we need to make sure we are offering that. And unfortunately, there are still many disparities. But I want to point you also to number 2 on here. Insulin pump therapy, preferably with CGM, should be offered for diabetes management to youth and adults on MDI, which is multiple daily injections with type 2 diabetes. That is also level A. And we have 3 insulin pumps that are AID systems that are now FDA approved for use in type 2 diabetes. So we also should be asking ourselves, for all the patients that need mealtime insulin with type 2 diabetes, have we offered them an AID system? And then lastly on here, the choice of device should be made based on the individual's circumstances, preferences, and needs. We are very fortunate. We have 6 different insulin pumps, 5 different algorithms. So there are choices, and we should be offering those choices and helping the person come up with what may work best for them. All right, so what are the different pumps? What are the different integrations? So you can see on here, these are the 6 different insulin pumps that we have available. And currently the t:slim X2, the Mobi, as well as Omnipod 5 and the MiniMed 780G have all been cleared for use in type 2 diabetes, which is very exciting. That all happened in the last year or so. And then you'll see like, wow, there's a lot of different choices for CGM. So they're not all compatible. So we need to pay attention to that. That, you know, if someone's going to be using a twist, for example, currently that's working with Libre 3 Plus, and in the very near future, it'll work with Eversense. But Dexcom at this very moment isn't compatible. So knowing that can help someone determine, okay, what sensor are they going to use depending on what AID system that they are on. Okay, so now we are going to transition to a second very important topic, and that is the burden of DKA. And so that brings us now to question number 2. DKA is associated with all of the following complications except cerebral edema, memory deficits, hypoglycemia, or death. Unfortunately, none of them great things, right? Dun, dun, dun.
We can do that next time. We get it. Dun, dun, dun.
Dun, dun, dun.
A little football music in
This
there.
is the dancing time.
You know, you're gonna dance because you're closest
Yeah.
to
You,
the
you
stage.
did threaten to dance earlier.
I did.
So we remember.
I did.
All right, you guys did a very good job. Yeah, exactly. Hypoglycemia is the correct answer because DKA is a time of typically extreme hyperglycemia, and unfortunately can contribute to cerebral edema, memory deficits, and even death. And this actually goes along very well with the previous topic of AID systems and insulin pumps, because when someone is when using an insulin pump, despite the fact that, yes, it improves outcomes, it improves time in range, it improves A1C, it also can increase someone's risk of DKA because they're no longer taking a long-acting insulin. And if something happens to their pump, if they get an occlusion or they take it off and forget to put it back on, they could go into DKA more quickly. So what is happening in the case of DKA? This is an insulin deficiency. So this leads to increased blood glucose levels, which leads to urinary glucose excretion, fluid loss, and dehydration. And then there's inadequate intracellular glucose for energy production. So what does the body do? It needs energy. So it starts to break down fats, which produces fatty acids and ketones. And as these ketones accumulate, they cause acidosis in the blood, which can lead to, unfortunately, it can lead to dehydration, but also death and acidosis. So we know that DKA is associated with significant complications and mortality. And I think we forget that sometimes, that especially people with type 1 diabetes who don't produce insulin, this is always a risk, and people die of DKA. Even with our great medical interventions, people are still dying from DKA. Even kids still die from DKA. And if they don't die, they still have these increased risks of memory deficits, of chronic cognitive issues, cerebral edema. And then of course, the cost of the hospitalizations as well. So that brings us to, gosh, if there's a way that we can prevent DKA, that sure would be very, very good. And we have ways to prevent DKA. We can do ketone monitoring, but it's kind of like when you think about where we are with glucose monitoring, we're like in the olden days of ketone monitoring. We have urine strips and we have blood strips, and that's what we ask people to do to monitor. So it's not surprising that only 20% of participants in a type 1 diabetes registry actually were monitoring, actually even had a meter and were actually monitoring. So that brings us now to our third topic, which is continuous ketone monitoring. Wouldn't it be great if we had an easier way to monitor? So my question for you in this section is, a continuous ketone monitor measures which type of ketone? And our choices are beta hydroxybutyrate, acetoacetate, acetone, or all of the above.
Last question, get in there. This is it.
Yes, come on,
This is the big one.
gurus.
This will take us to the end.
I've
the
like
final.
adopted you. I'm rooting for you.
Very
Glucose
nice.
gurus.
Well, that's okay. You can have an adopted team.
Well, I
That's
like
good.
the competition. You know, I want to be on a team. You can have the Mavericks.
Oh, okay.
Oh, I guess that means I get the ketone keepers.
You do.
All right, come on, ketone keepers, go.
Virtual is the way to go.
Okay, you guys are, so we got 31%, right? So beta hydroxybutyrate, and this one's probably a little bit harder, right? So beta hydroxybutyrate is actually what's measured in the blood. And then this is also what the continuous ketone monitor, which is measuring interstitial fluid, it would also measure beta hydroxybutyrate. Acetoacetate is actually what's measured in the urine, and then we don't measure acetone, which is why all of the above is definitely not correct. So let's talk about this a little bit more. What would this look like? And so if you had a continuous ketone monitor, it would look and feel just like a continuous glucose monitor, except in addition to only measuring glucose, that sensor would also be able to measure that beta hydroxybutyrate. And you would have one device where in your phone app or in your reader, you would be able to see if your ketones became elevated and if your glucose became elevated. And you might be thinking, well, isn't glucose enough? Like, why do I need to know my ketone levels? Well, it turns out that some people can go into DKA at much lower glucose levels than others. So simply only knowing your glucose level, you could be 250, one person could have high level of ketones, another could be completely fine, which is why being able to monitor this would be so helpful. So when should people be checking ketones, especially right now where we don't yet have a continuous ketone monitor? So every person with type 1 diabetes should have a way to measure ketones because they don't make their own insulin. And so they could go into DKA much more quickly. But it's actually not only people with type 1 diabetes. So people with type 2 diabetes, especially those that are taking insulin, if they are also taking an SGLT2 inhibitor, they are at increased risk of DKA. And in fact, we've seen many cases of euglycemic DKA where their glucose levels are not very elevated and they still go into DKA. In addition, in my practice, I can tell you there are a lot of people that think they have type 2 diabetes and actually have type 1 diabetes and are much more prone to going into DKA. Additionally, when people are sick or stressed, this is a time where they are much more likely to develop DKA. And in fact, the symptoms like feeling nauseous, vomiting, those can easily be confused with just being sick. And that's why many people don't monitor and don't even think they could be going into DKA. And then another area I want to mention is pregnancy, because pregnancy, especially with pre-existing type 1 diabetes, is a time where someone could go into DKA, which can be devastating for mom and the baby. But also, we often struggle with, well, how many carbohydrates should a woman eat in pregnancy? And even our guidelines, there's differing opinions on that. But if we can monitor their ketones, we can see if someone is eating enough carbohydrates, because ideally we don't want the person to have ketones. So what about continuous ketone monitoring? Who is going to benefit the most? Which groups should we be using this for? In my mind, if it's the same thing as wearing a sensor and you've already going to be wearing CGM anyway, and it's the same size, it doesn't feel any different, why wouldn't we want to monitor both? In my mind, even if we prevent one case of DKA, you have 100 people, they're all wearing it, if you prevent even one case of it, to me that's a win. When you think about the devastating outcomes that can occur, the cost of the hospitalization, but really more people than that would be able to benefit for it. We know people are at higher risk with certain medications, like taking SGLT2 inhibitors when they're fasting for procedures, when they get sick, when they're traveling and their schedule is completely off. And often it's not like someone's carrying their blood strips or their urine strips and saying, oh, now I'm going to test, because people are sick or they're traveling or they're jet lagged and they're not thinking about it. So if they had a device they were wearing anyway that could alert them, your ketones are high now. And the other thing about this is we should be giving people ketone action plans. So they know when their ketones get to a certain amount, what do? You drink more fluids, or you give more insulin, or you take in some carbohydrates and take insulin. And we could save on provider phone calls, on hospitalizations, on ER visits. There's really so many potential benefits. And so with that, I turn it back over to
All right, Dr. Isaacs, thank you very much. Don't forget, we've got Q&A coming up as well. All right, so let's get to it. How did the competition do here? Let's go ahead and get some of our results here and find us out. Here come the nerves, everybody that works. And the Keystone Keepers, the Ketone Keepers, that is. Look at that, right up top, 6,000 plus. So the Ketone Keepers, give yourself a nice round of applause. The glucose gurus, we were rooting for you.
At least they're not last.
They're not last. And those monitoring mavericks, boy, I'll tell you. They gave us a run for their money, but the ketones, congratulations. Now, let us go ahead and move on, because in the few minutes that we have left, thanks to the AMCP Nexus quiz show, we move on to Q&A. So I'll tell you what, Dr. Cornell, I'm going to turn this over to you to go ahead and take in the questions.
So awesome. Well, congratulations to our winning team. Good, Ketone Keepers. With that, several questions have come in. So first one I'm going to actually give to Dr. Isaacs. And I'm going to read this out so I don't mess it up. What types of data are most useful for guiding formulary decisions about CGMs?
Yeah, so I think, we have multiple CGM options. And when we think about what you would want on your formulary, you would definitely want something that can integrate with multiple devices. So with different insulin pumps for automated insulin delivery, we didn't talk about connected pens today, but connected pens are also another integration. And then there's certain features of different systems, like their types of alarms to warn a person if they are having an impending hypoglycemia, different high alerts or predictive alerts, mobile app integration. And I think these are all things that we should be looking at when kind of deciding what you would want on your formulary.
Good, thank you so much. And folks, if you did type in a question or you haven't submitted it yet, we still have time, so go ahead and, just a reminder, submit your questions. So this one I'm going to kick over to Dr. Triplett. And let me just find it here. Here we go. How reliable has CGM have been overall, and should patients continue to do finger sticks when their results vary with CGM?
Well, I think now we've gotten to the point where obviously you don't have to calibrate with the blood glucose, and I think that's very important to understand that a lot of these meters now the CGMs are so accurate that they don't have to be monitored and have a backup of the blood glucose. But that being said, I also want to make sure that it's clear that we still want them to have a blood glucose meter. And that's because of the fact that there's situations of hypoglycemia or extreme hyperglycemia or just uncertainty with CGM. Sometimes you could have your sensor dislodged. There's a lot of situations where blood glucose monitoring would still be necessary in your patient. So even though we want to say that that is a lot more accurate and the CGM is something you can use, but we want to make sure and be clear that the backup of blood glucose monitoring is and still should be available for your patients.
Yeah, and I'll just add, the ADA standards of care have a statement saying everyone with CGM should still have access to a meter and test strips. We don't expect they're going to need to use a lot of test strips, but they should at least still have that access.
And making sure too the test strips are in date, because
Yes.
we've run into those situations a few times. All right, I'm going to take the next question here. There's actually 2 or 3 questions coming in that are similar, so at least I'm reading them as similar, so I'm going to try to put them together. And it's talking about the variations between the readings we get on the sensors and what you get from the finger sticks, and the fact that those numbers can be different. And we kind of already, touched on this, but you have to realize finger sticks are testing blood, CGMs are testing interstitial fluid. And so yes, there can be a lag time, especially in a postprandial state. So oftentimes that lag time is not very long. It could be maybe around 20 minutes-ish, plus or minus, but again, it depends on the person. And so yes, there could be, but keep in mind too, the other things that affect, as we talked earlier, with finger sticks, you're testing blood. So if you have someone who has a low hematocrit, they might not be getting an accurate number. I know we've had several patients where we've done finger stick A1C point of care, and we can't get a reading because they have anemia. So what's causing this? And you have to kind of look at what could be the problem. But there could be a lag time. There could be, again, some type of a blood discrepancy. What's causing this? And you have to kind of dig deep, and knowing who your person is that you're working with. Oftentimes we see people with cancer who, again, have a lot of blood discrepancies. And so again, they may do a finger stick and it might not be accurate where the CGM will be, or vice versa. So again, it really is individual to that person. So the next question I have is, I'm going to start with, well, actually, you know what? I'm going to start, Diane, with you. Curtis, you can jump in and I'll wrap up. And it's about professional CGM. So how is the use of CGM, professional CGMs, changing, and how can pharmacists be prepared for this?
Yeah, it's a great question. I used to use a lot of professional CGM. And for those that are not familiar, professional CGM is owned by the clinic. It is worn by the person with diabetes, short-term basis, typically 10 days. And it offers an opportunity to be able to interpret their data. It can be blinded or unblinded, meaning they see their data or they don't. So the reason why we don't use it as much as we used to is because now the access to personal CGM is so much better. There's even over-the-counter CGMs now. So it used to not be that way. It used to be the coverage was very limited. It was at first only for people with type 1 diabetes, and then you had to be on mealtime insulin. And so it offered us a way that someone could get a taste of CGM. We could adjust their medications, and it was a great service for pharmacists to be able to do. But now, because of the improved access, we've really shifted more to personal CGM.
Yeah, in our clinic, one of the things I noticed is that we are still using some professional CGMs, and I think it's because of the lower socioeconomic group that maybe we take care of at the clinic where I'm at. And a lot of times they don't want to buy a CGM. The coverage is not great. Maybe they don't have great insurance. And so there are some situations where using a professional CGM helps us to get the data we still need, but it is a lot less common than it used to be because of the fact that CGMs are so prevalent now and access is increasing.
And I'm going to kind of shift to respond to that second part of the question. I think all pharmacists need to be prepared for CGM. So again, dating as the veteran, I'm going to say vintage, the vintage person in the room, experienced vintage person. One of the things back when I graduated from pharmacy school, we were just learning about finger sticks. That was the new thing. Today, that is or was the standard of care. All pharmacists became familiar with it over time. CGM is the future, and that's what I tell a lot of the young folks that I work with, my students. this is their future of pharmacy, not only in diabetes, but in other disease states. And my last question that we'll cover here is kind of coming through from several of you about CGM use in non-diabetes patients. And again, CGM is so powerful, it could be helpful for patients to make life decisions. So I think pharmacists need to be prepared for this, and there are several opportunities. I know many of the big associations have certificate programs. There are a ton of CE available on this. So the more you know about CGM, the better you can help other pharmacists who are practicing, as well as the people with and without diabetes. Which leads me to the last question that we're going to wrap up. And again, there's probably about 4 or 5 of you with the same question about CGM use in people without diabetes. And so, Curtis, I'm going to start with you. And some were asking specifically in use with non-diabetes using GLP-1s.
Yeah, so I mean, we have a lot of people out there right now using, we are siloed. So there are weight loss drugs and there are drugs that we call them diabetes drugs, but the answer is they're the same drug. And so one of the things is that a lot of times this is still giving good feedback to our patients. A lot of patients who we call quote unquote non-diabetes still may have prediabetes. And in that prediabetes population, using these types of medications is still going to give a good feedback, and a CGM is going to help augment that information for the patient, because a lot of these patients who are have prediabetes can also use that biofeedback in order to get data for their physical activity and for their diet interventions that they may or may not be doing.
Yeah, and I think you brought up a good point earlier, Sue, with your students, like gaining valuable feedback. I think we can all gain valuable feedback with or without diabetes. One of the questions, though, is like, what's the right dose of CGM? A person without diabetes probably doesn't need to wear it. They could purchase an over-the-counter and wear it all the time, but they probably don't need to. And that's one of the things we're still trying to uncover. But I love the idea that it is more accessible. There's so many people with prediabetes or type 2 that don't know they have it. And I think by making it more accessible, people are learning.
Yeah, it is. It's a great self-awareness and self-education tool to help people better manage their diabetes. With that, I apologize. We are out of time. I know a few questions just popped in. We will linger, and if you want to come up and ask us your questions afterwards, we are happy to address them. With that, Ed.
Thank you. How about a nice round of applause for the brilliant vintage council? I like that. Vintage, very nice.
We're not all vintage.
Thank you very much.
No,
Don't forget to earn your CPE credit. Make sure that you get that as well. We hope you had a wonderful lunch. I'd like to thank our crew here today very much, and the people who help us virtually as well. My name is Ed Berliner from Edscape Live. Thanks for joining us, everybody. Have a great rest of the day, and thank you, faculty.
Thank you.